Bueno, buenos días para todos.
Good morning,
Hoy
everybody.
estamos
Today,
con la
we
clínica
have
ECO de salud
the
mental, psiquiatría,
Mental Health and
con su objetivo de
Psychiatry
articulación
Clinic at
justamente
ECHO,
entre los
and the
niveles
idea
de
is
la
to
intervención.
articulate the
Y para
different
nosotros
levels of care.
es una clínica especial porque
This
tenemos
is a
una
special
invitada
clinic because we have a
con la
guest
cual venimos
with who
trabajando desde
we
el
have been working
2021
since
y
2021.
justamente dentro de estos modelos de atención en
We're
psiquiatría
working with this
pediátrica
sort
que
of
tienen que ver
pediatric
con la cooperación
psychiatry
entre
models of
niveles.
care
Yo creo
related
que
with
no es necesario
cooperation among
decirlo,
levels.
pero
I think
vale
we
la pena para
don't
los nuevos, para la
necessarily have
gente
to say it,
empieza,
but it's important for people who are
señalar
starting and
que la
students. We must
problemática
indicate that the issue
vemos los psiquiatras de
we
niños, los
care,
psicólogos
child
que trabajan con la
psychiatrists and
infancia,
psychologists working with
son
childhood at
situaciones
present,
que no
care
pueden
for
ser
conditions
resueltas
that
en el ámbito de un
cannot be solved
consultorio y
within
con
a
un
single
recurso
office and
médico en
with
forma aislada.
isolated
Requiere la
medical
participación y
resources.
el trabajo
It
interdisciplinario,
requires
las estrategias
interdisciplinary
en
work
común y
and
sobre
common
todo la
strategies, and
cooperación a lo
particularly
largo de toda la
cooperation
rueda de
throughout
atención en
the
salud y
network of
con
care
nuestros
in the health area and together with
sectores, los otros
the
sectores con los cuales
other
trabajamos
sectors with
mancomunadamente,
who we
que
work
es la
together.
educación, y
That
en el
is
caso de
education,
nosotros,
and
Uruguay, y
in the case of
caso de otros
Uruguay in
países de
particular,
América
and
Latina,
as
todo
a
lo que
case
tiene
in
que ver
other
con el
countries
ámbito de
in
la
Latin America,
población.
the
Así
ambit
que
of
esta clínica
protection.
tiene ese componente
So this clinic has
y
a
vamos a tener
component
como
and
un aporte
will
muy
have
importante
a very
de una
significant
colega de Boston,
contribution
Deepika
from a
Shaligram, que
colleague
ha sido una
from
colaboradora
Boston,
desde el
Deepika
comienzo de
Shaligram,
este
who has
vínculo. Y
contributed
yo
from
quiero
the start.
contarles a
And
todos,
I want
porque me
to
parece
tell
que
you
es
all,
importante
because I think this is important
que sepamos cómo
for you to
es la
know
historia de los vínculos
about the
también en la
history
cooperación
of our
académica.
relationship in
Y este
academic
vínculo
cooperation.
inicia a
This
través de una clínica ECO.
relationship
¿Sí?
started
O
via
sea que
an ECHO clinic.
ECO ha sido no solamente el
ECHO has
soporte
not only
para
served
estas
to
instancias de
support
encuentro y de
and back
trabajo,
up
sino que
these
también propició
meetings and work
que nos conociéramos
relationships,
a
but it
través de otro
allowed
colega
us to
de
meet
Brasil, el doctor Flavio
via
Díaz Silva,
a colleague
que
from
se
Brazil,
interesó
Flavio
en la
Diaz
modalidad de
Silva, who
trabajo que
was
tenía
very interested in this
este
working
formato de
modality
proyecto ECO
in the
y nos
ECHO
puso en
project
contacto con todo un
and
grupo a
established a
nivel
relationship
internacional
with an
que viene
international group
promoviendo este
that has
tipo de
been
modelos. Yo creo que este
encouraging
modelo de
this sort of
trabajo
models. I think
está
this
en total
work model
consonancia
is
con
in
los
total
planteos que
agreement
nosotros tenemos en
with
la nueva
our
ley, la
position
ley de salud mental
according to
del
the new mental
17
health
y
law
lo que es
in
la transformación de los
2017
modelos de
and the
atención.
transformation of
Así que
models of
yo les voy a
care.
dar la palabra,
So I now hand the
agradecidísima a
floor,
la participación
and
de
I'm very
Deepika y a todos los
grateful
que se
for
interesaron hoy
Deepika and all those
por estar con
interested
nosotros.
in
Y
being
le
with
voy a dar
us
la
today,
palabra a la
and hand the
profesora
floor
asociada
to
Laura Canessa,
Professor
que va a
Laura
hacer la
Canessa,
presentación
who will
de
make the
Deepika
introduction.
y
She
también
will
la
introduce
presentación del
Deepika
caso.
and the
La
case.
agenda va a ser esa, vamos a
That is
presentar
our
el
agenda.
caso y
We'll
después
share a
Deepika va a
case,
tomar un
and
tiempo de
later
presentación
Deepika will make
didáctica y
a didactic presentation
también de contarnos y compartir
and tell
su
us and
experiencia.
share
Y
about
vamos a tener
other
seguramente un
experiences.
tiempo
And
de
then we'll
discusión, de
surely have time
intercambio.
for
Así que
discussion of
bienvenidos y
exchange.
muchas
So
gracias a
welcome,
todos.
and thank you for being here.
Laura, te doy la palabra.
Laura, the floor is
Gracias,
yours.
profe.
Thank you.
Bueno, buenos días para todos y
Good
todas.
morning,
La verdad
everybody.
que es un gusto
The
y un
truth
honor
is,
hoy estar acá.
it's a pleasure and honor
Quiero
to be
agradecer
here
especialmente al equipo de
today.
ECO,
I want to thank the
porque
ECHO team very
realmente las gestiones que han
especially
hecho para
because
lograr que
the work
esta
they've done to
teleclínica
make
se pueda llevar
this
adelante de esta
clinic
manera,
a
con
reality
interpretación, con intérpretes,
with
que recuerdo por
interpretation.
las dudas que tienen la
And
posibilidad
I
de
remind
elegir
you have this
idioma
possibility
para
of
escuchar
selecting the
esta
language
clínica,
to
ha
listen
sido
to the
muy valioso.
teleclinic, and this has been very
En primer
appreciated.
lugar, voy a
First,
presentar a la
I will
compañera que nos
introduce
acompaña hoy,
a
que
colleague
muy
who is with us today, who very generously
de su tiempo y de su
accepted
conocimiento para compartir con
sharing her
nosotros.
knowledge and time
Deepika Shaligram
with
es
us.
psiquiatra de
Deepika is a
niños,
child
adolescentes y
psychiatrist. She
adultos
works with
en el Boston
adolescents
Children's
and adults
Hospital,
at the
es
Boston
psiquiatra
Children's
adjunta
Hospital.
en los servicios de
She's adjunct
psiquiatría
psychiatrist
ambulatoria
in
y
the ambulatory
afiliada de salud global y salud
psychiatry
vital.
department
Es
and
codirectora
works
del
in global
programa de
health.
acceso a la
She is
salud
director of the
infantil del
Access
Boston
to
Children's
Child
Hospital de
Psychiatry
Massachusetts y
program
del
at
programa de
the Boston
observación de
Children's
psiquiatría
Hospital,
internacional.
Massachusetts, and the
Sus áreas de
International
interés
Observation
incluyen el acceso
ambit.
a la atención,
She all
la educación
works
y la
with
justicia
access to
social.
care,
Es miembro del
healthcare, and
Comité de
social
Cambio
justice. Is a
Climático
member
de la
of the Climate
Academia
Change Committee
Americana
at the
de Psiquiatría de
American
Niños y
Academy
Adolescentes
of child and adolescent psychiatry and co-chair of the Diversity and Culture Committee. She is part of the board of the Child and Adolescent Psychiatry Board in New England and the Institute of Family Processes, member of the American Psychiatry Association and distinguished member of the Children and Adolescent Psychiatry Association. She collaborates in the Journal of Child and Adolescent Psychiatry and likes to teach psychopharmacology, family psychiatry and collaborative psychiatry, and additionally is extremely generous with her knowledge. She's really helped us all open this possibility of participating in different collaborative events, and we're very grateful for that. Next, if you agree, we'll hear the clinical case, where I also thank other professionals in the territory for being present. Of course, we're going to share the case from hospital, but with us we have Dr. Gabriela Garrido, who is a child and adolescent psychiatrist. She's the treating psychiatrist in the territory where the child we see is cared for, and other professionals in the team in the Enjoyable School program is Terzoria, Social Security, and psychologist Dota, who are also aware of the situation and will help us to think and extract in this regard. If you agree, we share the form. Beside me, we have part of the team, we're many. Deepika saw them, but this is a team that cares for this case, Dr. Maqueira and Dr. Pastorini, who will also share the presentation. Good morning. We're going to share the case of a 10-year-old girl from Montevideo who is in the 4th year of primary education. She repeated 2nd year, and since March 2025 has a scholarship in a full-time school close to her home. Before she went to a public school, at school, the school is familiar with all the siblings. Other activities she conducts, at present, she doesn't have other additional activities. She attended a treating clinic via the social security system. Regarding her family, the mother is 29 years old, has a good cognitive potential. She works informally. She has 4 siblings of the mother with different fathers, and she lives with the older sister, 11 years of age, and a baby that is 18 months. The other children live with the father's family. She is not aware of her biological father. The couple of the mother, the father of 2 smaller children, is no longer living with them because he is accused for child maltreatment and has restriction measures in relation to the 2 older girls. Anyhow, she visits her home frequently and the younger sibling and supports the family economically. As for the social, economic, and environmental history, since 2021, B has lived with her mother and the 3 mother's other children. In the past years, she lived with the mother's couple, the father of the 2 younger children. The maternal grandmother has been present throughout this period and lives close and has cared for the child. They come from deficient social, economic, and cultural milieu. The grandmother has 10 children and has a relationship with only 3. As for the family history, the mother has a psychiatric condition. She is overwhelmed by impulses during childhood and adolescence, not treated, received psychiatric and psychological care 1 year after 2021 when she was denounced for maltreatment to the 4 children. The youngest hadn't been born yet, and restriction measures had been imposed. We are not aware of the mother's diagnosis. At present, she's cared for in the private provider. We don't know of other family history issues. As to the perinatal history, pregnancy, delivery, postpartum, it's a second pregnancy that was stressful with little family support networks. She denies perinatal conditions, and the landmarks of neural development were normal, as expected. As for the personal pathological history, she has been described as a difficult temperament, crying a lot, hard to calm, irritable, with hetero-aggressiveness early on, difficulties in the kindergarten, difficulties with boundaries and accepting them without other remarkable things. As for the development, it's in agreement with what is to be expected, good cognitive potential, autonomous and independent in the everyday activities. As current clinical issues, she presents marked difficulty in impulse control with hetero-aggressiveness crisis triggered by minimal stresses, with boundaries and in relation to third-party behavior that she perceives as threatening. They require contention with words. These episodes are repeated in different ambits: a mother's house, a grandmother's house, the minors' institute, and at school. At school, they say that once she placed a bag on her head, and that was a cause of concern. As to prior diagnosis, failure in impulse control, attention deficit, hyperactivity, affective and behavior dysregulation, and is receiving psychiatric care since 2023. As for the assessments conducted, we have the WIS, the Bender test, a WIS accounting for low, medium functioning, if we consider the levels and each of the indexes, she attains normality and low normality levels. In the projective stance, it has excessive control of anger, hostility. She struggles for power and the need to compensate weak contact and aggression. Basic insecurity, no baseline psychic pathology observed. We don't observe elements guiding us to specific difficulties in the pedagogical, visual, motor, spatial, and attentional areas. We don't observe indicators of psychic baseline pathology, although we do detect elements in the psychoaffective order, defensive mechanisms for aggression control, and baseline insecurity. In 2021, the mother and the couple were denounced at school for being violent among themselves and towards children, so all the children are removed from the home and go to a minors institute. These mothers and the spouse were not allowed to approach the children due to court order. Later, B and her sister, her elder sister, go to live with her maternal grandmother. In 2023, she installed psychiatric treatment close to the home because she has difficulties in impulse control and low tolerance to frustration, with episodes of anger and aggressiveness to the peers. She's medicated with antipsychotics and with stabilizers, risperidone, experiment with good response. This year, she was assessed at psychodiagnostic level, and she is followed in the territory. In 2024 October. She enters a minors institute home because the grandmother was ill and had to go to hospital, and there were no other adults that could care for her. The sister went to live with the father's family. The mother and the couple was still with restriction orders. At the minors institute home, she has more behavior disorders and is admitted to the children's hospital to be assessed due to court order. During hospitalization, B manages to adapt. She didn't have behavioral disadjustments. She attended the interviews in a pleasurable manner, participated in recreational hospital activities, and in the hospital classroom. She managed to establish a good relationship with the health team. Initially, she had a defensive attitude, but later managed to establish a relationship generating empathy and wishes to help. On occasions, she was particularly irritable and challenged limits, but with the help of adults, managed to reflect, allowing her to change her attitude. The symptoms of this child seem to be reactive to multiple traumatic and stressful situations she has experienced during this time. All the players exchange their views and suggested controlling with close follow-up in psychiatry with a psychological approach that was made reality in December 2024. Since then, to date, she had a simple consultation in the Pediatric Emergency Department at the Children's Hospital in April 2025 and was discharged to the home to be followed in charity. In February 2025, the child and her older sister went back to live with the mother. She has a younger sibling, 18 months old. The mother's couple still has restriction measures to be and her sister, measures that the mother does not totally respect. She starts fourth year in a public school, but because she has behavioral issues, the mother changes her to a private school where she also shows difficulties and she is told to less hours to school. The mother requests aid from the Minors Institute team accompanying her in the territory. 12 days ago, she entered hospital for the second time due to court order because at the Minors Institute team, working with the family, they request she be hospitalized in a specialized center in issues of mental health. At the time, she's interviewed with the mother and the grandmother, and there is a new communication with the treating psychiatrist and different institutions working with her family. The mother says that she is an intelligent girl that pays attention, has difficult temperament since early on, irritable and aggressive. She's a child. She was difficult to calm as a baby. She bit and hit her peers in the kindergarten. She has difficulties to accept limits. She feels angry and is aggressive, although she manages to reflect with an adult and explain things. The mother acknowledges she had a similar behavior when she was a girl and adolescent, with difficulty to respect boundaries and impulse, lack of control, making her react violently towards the children. She acknowledges that B manages to control her anger when contained affectionately and offering security. During 3 interviews, the mother states she wants to care for all her children. She received psychiatric and psychological treatment during a year, but at present is not being treated. During this admission, B shows affection towards the health team. She's interested in attending the hospital classroom daily, although she has difficulty in accepting boundary and has aggressive manifestations. She threatens and hits on 2 occasions. The caregiver at hospital, on 2 occasions, he hits her head against the wall and she's contained with words. On 1 occasion, she received her OAS medication. On the 23rd May, she had a psychomotor excitation crisis and received physical containment measures and was referred to an acute center because the pediatric ward team stated they couldn't continue with her in hospital in moderate care. We do regular treatment and follow-up with pediatric psychiatry since December 2024, psychological and psychopedagogical approach weekly in the Social Security Center, and as for pharmacological treatment, she was receiving sodium valproate 500 milligrams a day, aripiprazole 10 milligrams a day, levethromycin 25 milligrams, and methylphenidate 20 milligrams.
Bien. Capaz que
maybe
quizás tengan alguna pregunta
there are questions
que podamos responder o que pueda responder
we could answer or the territory team could answer. We wanted to share this case due to the different components included. We're interested likewise in considering the adult psychiatry view on everything regarding the different difficulties we've faced throughout this patient's history that somehow question us. So we wanted to make the most of this possibility of having Deepika with us to think about collaboration among the different levels of care. Carla Vivas asks if the mother took was a substance abuse person. She denies this, but she does acknowledge that she fails in impulse control. The mother says that she cried more than me and never received psychiatric care when she was a child. During in 2021, when this mother and her couple were denounced due to child maltreatment, it was decided that she received psychiatric and psychological care. So this lady received treatment during 1 year due to this court order. This ended, he didn't maintain that treatment after the year, and the different interviews we've had, Dr. Ferreira has also interviewed her and we've exchanged in this regard. And what occurred in the 2 admissions of the patient, October last year and this one now, we didn't observe a deterioration and impairment in the child, but on this occasion, we did have the chance to meet her mother, because in the previous occasion, we had met the grandmother, who was a person. Well, she was at hospital, but she was responsible. And in summary, then, we wanted to bring this case that has behavioral symptoms in the patient characterized by impulse discontrol due to minimal frustration, but that ultimately have been reversed and solved with words and with, and I'll give you an example, just to give you a better idea. She's an intelligent girl. She knows the medication she takes. We made some adjustments throughout the admission and speaking with the nursing staff, because every day we went to the ward and talked with the physicians and nursing staff to know how things had been. And the nurse said, yesterday when I went with the 2 pills of the valproate, she said, why 2 if I only take 1? And didn't want to take the second. So the nurse said, I explained that you had made this increase in the medication. That was a measure taken by the physicians, and she accepted. By this, I want to show that this girl needs to know what will happen. She hasn't been told many things in anticipation, because when we met her at hospital, for example, this was because the grandmother had a medical condition and had to be in hospital, and there wasn't any other adult because the mother had the restriction measures. So she ended in hospital, well, first in the Miners Institute. This is a children's home under state protection, and because the behavioral issues increased, she was admitted to be managed. Maybe you, Daniela, or the other team members of Enjoyable Schools wish to add on to contribute to the discussion. Add on whatever you think is necessary. Hello. What I would add is that ultimately in 2021 the patient went to a children's home belonging to the Miners Institute via the family reception, family friend program. They find the grandmother, so the older sister and the patient go to live with the grandmother, and the younger sister goes with the paternal grandmother. And since then, this program follows the patient regularly. They visit her every week. The patient, since I know her, and starting in April to date, with permanent, regular control, the grandmother was constantly responsible, and the patient didn't present any element of behavioral maladjustment. But this did occur in other ambits. The school where she attended was the same where she went initially. And since then, we already observed elements that have been mentioned. Physical elements of violence from the mother. When last year at school, where there's this exacerbation at behavioral level, they reduced the school hours because of this issue. And in the end, she stopped going to school. She went less and less, and then she had a community teacher working with her at the home. And in September, I began to see her in April. We had this behavioral exacerbation. In the family reception team, we had concern about the new relationship with the mother because although it was restricted, she and her sister wanted to visit the mother, and on several occasions the team was in the ambulatory clinic concerned about the patient's behavior that seemed to worsen, and because of the condition of the grandmother, because she had difficulties in taking care. When she entered in October, it was due to another behavioral decompensation. So she went, because of the behavioral issue, to hospital. And this year, in February, when the mother began to visit for 3 hours, and in December it was decided to re-establish the relationship with the mother with visits, and in February she began to live together with her older sister and her mother. And the reception team conducted follow-up visiting the mother. There is a change in the home and the change in the institution. And last year, court decided she have psychotherapy through an organization. She has poor compliance, but she receives follow-up. And this year it was decided that she entered a psychopedagogical center in agreement with the Social Security. So there's a new change in the technical people doing the psychotherapy. So it's a new clinic, a new technique with the psychological and psychopedagogical approach. So in this past period, there have been many changes for this patient. And in April, she is readmitted. And she consults in the emergency, she's discharged, and somehow in the family reception team, they speak about increased behavioral symptoms. And on the 9th May, once again, the team notes the behavioral issues requiring admission to hospital to assess if it's convenient for her to remain in the home or to be admitted to another center where she could have a different sort of protection. Basically that.
Gracias, Daniela.
Thank you, Daniela.
No sé si hay quizás
Any
preguntas o algún comentario.
questions or comments?
Perdón, voy a mirar el chat.
Let me look at the chat.
Preguntan si la abuela aún sigue
They
presente.
ask if the grandmother is still present in the child's life and can be responsible. Yes, she is present in her life. Indeed, she contributes with care, but she herself says that she has a medical condition and could be totally responsible for the child. She also makes it clear repeatedly that she cannot be totally responsible at economic level, So what she could do is somehow to support care. She says, they can bring her every afternoon, I can take care of them, but not much more. The mother states that she wants to recover all her children. She has 5, of which 3, this girl, the elder, and the small baby that was born after the restriction measures to the others, and the other 2 girls that live with the paternal grandparents. The lady hasn't reestablished a relationship with one of these, but what she says is that she would like to have all her children with her. Ultimately, she sort of downplays these situations of violence. She says that although they occurred between her and her couple, this is what she says, it wasn't that important or that significant in her view, that the violence towards the children wasn't that severe. And what concerns the team in the territory, and they stated it at the meeting we had a few days ago, is that the lady doesn't respect somehow the restriction measures that her couple still has, because this gentleman, although he doesn't live with her, goes to the house and conducts different tasks, maintenance. When we discussed this with her last week, he said, well, but then who will mow the lawn? Because if the people come from the Minors Institute to look at the home to see if it's good condition, to have the children shall look at the condition. So somehow she sort of justifies the maintenance of the relationship, and it's clear that there's an economic dependency with this gentleman, because he pays for the gas. So she comes in the motorbike to visit the child at hospital. So we somehow understood that this relationship is still alive, not only at affective level, but also economic. So we understand this makes the situation a bit more complex. What do we know about the early relationship between B and her mother? Attachment, or she was desired. Well, what we said at first, the mother is very identified with this girl. She says she was the same but worse. And when we asked her, it's clear, and she says this, all her children are of different fathers. In fact, they haven't lived with their fathers, with the exception of the 2 younger children, because they are of this current house with the restriction measures. And ultimately, maybe it is worthwhile adding, to make things more complex, that the grandmother, this lady that is present in B's life, has 10 children, of whom she currently relates live children, only has a relationship with 3 out of the 10. So, if you think about early relationships and how attachment was built, maybe there are questions there. When working with a mother, something that causes concern, and we wonder about this, is what should we continue doing? What are the future strategies? Our questions were, would the solution, quote unquote, to this matter be that the child be admitted to what we call middle of the road care center for mental health care? We don't really have a solution to this complex issue. We don't rule out, together with Dr. Ferreiro, that this could be part of the strategy. We thought it wasn't necessary right now, but perhaps each component has its complexity and makes it harder to solve. Gabriela, the floor is yours.
Bueno, no, creo que en la transmisión de
Well,
la
when
historia
conveying the
se
case
ve
history,
también
I think
la
it's clear
multiplicidad de
that there are
participantes, ¿no? Si
multiple
uno quiere
participants.
pensar
If you
en el
think
número de personas que
of
intervienen,
the number of people
en los costos,
intervening and the
además,
costs,
realmente
truly,
es para reflexionar,
it's something we
porque
must
los
think about,
resultados no están
because the
siendo lo que
outcomes are
uno
not
pensaría
as
que deberían ser.
we think
Quería aclarar también un
we
poco
ought to have.
para
And to
Deepika,
further clarify for
que
Deepika,
ni el hospital ni
neither hospital
otros efectores de salud
nor the
cuentan
other
con
health factors
dispositivos de corta
or
estadía,
providers have
o sea que cuando
short
se habla
stay
de clínicas de agudos son
possibilities. So when we
absolutamente
say acute
privadas y
patients, it's
fuera
private
de
clinics
el
beyond
control y seguimiento del
uh,
sistema.
control
Eso
and
creo que es
follow
muy
of the system,
importante.
and that is very
Lo
important.
otro, que en toda esta
And
historia
additionally, in
estuvo
all this
faltante
history,
el tema de
what
la
was missing
evaluación de estos
was
adultos, ¿no?
the assessment of the
En
adults.
el caso del hospital
In the
también
case of
va a
hospital,
cuenta de una
this
carencia que tenemos
is
en
because
este momento,
of
de
a
que no
lack we
estamos
currently
contando
have,
con recursos
because
de
we don't
psiquiatría de
have
adultos
adult
en los
psychiatry
equipos de
resources
gobierno.
in the
Aclaro
health
esto porque
hospital team.
parecen piezas
And I
claves
make this clear because they are
y
key matters
importantes, ¿no?
that are missing.
Entonces,
So,
me parece que podemos de repente, Laura, ir
maybe
abriendo ya
Laura,
las otras
we can
intervenciones
open
y poder
the
dar lugar a la
floor
presentación de
and
Deepika.
later listen
Sí,
to Deepika.
sí.
Yes,
Quizás sí, porque son
yes.
10:40.
It's 40 past
Deepika,
10. So
volvemos a agradecerte, Deepika. La
thank
verdad que
you
es un
so much,
gusto
Deepika. It's a
que nos
pleasure
acompañes hoy.
to have you with us today.
Y Deepika se va a referir, vamos
She will speak.
poniendo su presentación.
Let's put your
Sobre
presentation
el
on screen.
programa de acceso a la
He
psiquiatría
refers to
pediátrica,
the access
desarrollos
program to
recientes y
pediatric
nuevas
psychiatry,
orientaciones.
recent developments and new guidelines.
Thank you so much for your kind introduction this morning and thoughtful case presentation. I am going to be talking a little bit about my program, which is the Massachusetts Child Psychiatry Access Program. I really appreciate this opportunity to be with you this morning. I'm going to share my slides here. As was mentioned before, I am from Boston, Massachusetts, and our Child Psychiatry Access Program goes by MCPAP, MCPAP. And in terms of background, how our program was developed, in the US, 15% of children have some form of a mental health condition, but because of workforce shortage in child psychiatry, less than 50% are receiving treatment, and about a third who do receive treatment get their medications and management from primary care doctors. So there was an idea developed that centralized coordinated care by child psychiatry would provide rapid remote consults for pediatricians to manage mental health presentations within primary care. This reduced stigma, problems of needing to travel, and this was particularly important in underserved areas outside of cities and the two coasts of the US where most child psychiatrists reside. So in a nutshell, our Massachusetts Child Psychiatry Access Program was the very first program in the entire country. We currently have all 49 states with a Child Psychiatry Access Program, and there is a new program developing in our 50th state. And it all started back in 2004. Because of shortage of services, the state government of Massachusetts funded this program, and later commercial insurance also joined with funding the program. Essentially, the phone consult by the child psychiatrist allows for preceptorship of pediatricians so that they can provide the mental health management in primary care. And this program, MCPAP program, has created several innovative new branches, which I will be talking about in just a little bit. You see the three core services in the blue rectangle. They are phone consultation as well as direct face-to-face consultation, care coordination services. So if there are community resources needed, that is provided as well, and training and education for primary care clinicians. And this is what the workflow looks like. If you have a primary care clinician who is seeking advice, they pick up the phone and they call us. And on the other end, we would have either a child psychiatrist or a child therapist, psychology or social work level. And then if the pediatrician just wants resources in the community, for instance, somebody to work with the family, like this patient that was described, this 10-year-old girl, clearly needs a family partner that can work with the mother to help the mother manage the child's behaviors at home. So that's one of the services that we get with our care coordination consult. And then if there is short-term therapy needed in the community, then that is also available to this program until the community therapist is available for ongoing care. In terms of quick facts, why we get the phone calls, the reasons are, you'll see towards the bottom, most commonly when there's a question about diagnosis that the pediatrician wants to clarify. If they want resources in the community, whether it's a therapist or a family partner, if there is a need for parent management training, so a special form of therapy that helps parents work with their children with behavioral conditions, and finally, medication management. So far, we've had 28% of our phone consults become direct consults so that the child psychiatrist sees the patient directly. And the kinds of recommendations we make on our phone consult outside of making diagnosis and medication recommendations, we also talk about level of care. And that was one of the questions that came up with this 10-year-old girl as well, because she had been admitted to the hospital. She had been with the Department of Children and Families, Social Security. So the level of care recommendations are also something that we do in this program. So this is the numbers in terms of consults we had for the 2018 to the 2019 year for the program. As you can see, the bulk of the phone consults are actually retained by primary care. Only a small proportion go to from phone consults to direct consultation. So in our state, more than 500 pediatric practices are involved with our program, and that covers more than 95% of the children in the state. So when we had our pandemic, there were a lot of calls for child mental health crisis. The U.S. Surgeon General declared a national emergency for child mental health. And at that time, we also started having our trainees, our child psychiatry trainees, handle some of the calls because there were so many. Other things we did is to have telehealth, just like we are doing now, to provide both clinical services as well as education. We also started providing consultation through the electronic medical record. So the pediatrician doesn't have to call us on the phone. They can message us through the electronic medical record and say, please see the record of this particular patient. I'm having troubles managing ADHD. So we go through the record and then we make recommendations for medication or therapy as needed. We also provided bridging care. So if we determined a patient is too complex for a pediatrician to manage, then until the community psychiatrist can see the patient, we did some follow-ups and managed the medication for about 3 or 4 visits. We've also developed some specialty branches during the pandemic because we found a lot of teens were beginning to use substances. They did not have to go out to school. They were doing remote school. They didn't have friends. And as a result, there was an increase in substance use problems, as well as for autism spectrum disorder, there was a problem with getting services into the home. You will see that in this graph, pediatricians are saying that the consults are useful, that they are timely, and they meet the needs of the children with the mental health problems so that they are able to be managed in primary care. And this is spanning 2008 to 2012. So to sum up, for performance highlights, we see about 6,000 children per year as phone consults. And that represents about 25% of children with severe emotional problems in the state. Within the pandemic, though, the numbers went up. So the orange line refers to the pandemic year, and you will see that this has a dip during March, April, May, when we had a lockdown and nobody was going out of the home, so we were not getting any consults. But the next year, in 2021, you will see the same time there was a huge peak in consults. And this was because kids with autism spectrum disorder, anxiety, depression, and substance use, especially vaping, became a huge problem. I am going to transfer a little bit, segue a little bit into some of the tools that we have for pediatricians to manage behavioral health conditions. I have about 4 care pathways that we developed based on the practice parameters for the American Academy of Child and Adolescent Psychiatry to make diagnosis and to treat. It is all in one page, available as a free resource on our website, mecpap.com. So a pediatrician can pull this out at any time to look at it and see guidance. Our phone consultations also use this so that across our 6 hubs, MECPAP has 6 hubs with different academic medical centers, we give the same recommendation. So right on the top, we see a broad screen, which is the pediatric symptom checklist. If it is positive, say for depression, then we do a narrow band instrument, which could be the Moods and Feelings questionnaire for younger children or patient health questionnaire for older children. Then towards the middle of the slide, you'll see mild depression, moderate depression, or severe depression. So the scale will tell us what the level of the depression is. And then it walks us through what medications are FDA approved or have empirical evidence for use in children. So that you see in the green box. It also says for younger age groups, what is the starting dose? For older age groups, how to increase the dose as we go along. And right to the bottom of the slide, it says how long to continue the medication, what if the medication doesn't work, and gives strategies of how to taper and stop the medication once the episode is resolved. Similar pathway for anxiety. I wanted to highlight the green rectangle in the middle. Also talks about treatment of conditions like panic attacks with medications like hydroxyzine, because panic attacks are very disabling to the child, and our medications for anxiety and depression take 6 to 8 weeks to kick in. So panic attack medication is so important. And if it is used at a higher dose for sleep, a child who is not sleeping is going to be behaviorally dysregulated the next day. So that is mentioned in this chart. To the bottom, it also says how to increase the dose, how to taper and stop the dose, and how to change medication from one SSRI to another if it doesn't work. This is the ADHD care pathways, very similar. I wanted to pause here for just a second and look at the bottommost rectangle. We know our 10-year-old child had taken ADHD medication, methylphenidate, 10 milligrams, immediate release. Is it possible that that medication did not last through the whole school day? That is why we were seeing some impulsivity in behaviors. Are there other options for treatment? So in this particular pathway, we use the Vanderbilt ADHD rating scale, which both the school will rate, so the teacher, as well as the parent will rate. And we'll know what the problems are in both those places. And that will help us fine-tune medication. In the bottommost rectangle, we have three classes of medications represented. So in the methylphenidate group, would it help to have an extended release methylphenidate to cover the whole school day? Or should we change from methylphenidate to the amphetamine group? That is also mentioned here. So FDA approved. So FDA is a national drug enforcement agency that approves use of specific medications for children. And so this is an FDA approved medication, Vyvanse, that is listed over here. Adderall is also an option. And to the bottom, we have alpha agonists. So the alpha agonists are also something that we might want to consider in impulsive, dysregulated children, just like this 10-year-old, because the alpha agonists will help with the impulsivity, even if it is coming from trauma. And we know that this 10-year-old girl had so many traumatic events, right from child abuse to separation from key caregivers, attachment figures, first her mom, then her grandmother, and then moved to a state home when her grandmother was in the hospital, reattaching to mom, which was also traumatic, and then change in the school. Changes in familiar environments are extremely dysregulating for a child who's fragile. So in all these situations, the alpha agonist can be so very helpful. This slide, I feel, applies the most to our kid. So this is for trauma. We have screening questions. For instance, this child is over 7 years old, and we would ask this child, has anything really upsetting or scary happened to you and your family? And we would list out all the different adverse childhood experiences, or ACEs as we call them. And then we would say, does social security need to be involved, which is what filing a 51A is, which very appropriately this child is involved. If there is immediate concern for safety of the child, then we would hospitalize either through the emergency room or calling a crisis team. And in the hospital, and if we determine hospital is not needed, in the outpatient clinic, we would administer the child and adolescent trauma screen. So based on the scores right in the middle, you see moderate trauma-related stress. In that situation, we with close monitoring for suicidal ideation and self-injury, we start up with therapy. With mild conditions, which is on the left side of the screen, we provide parent support and child support in the form of therapy at school and in the home environment. So we have in-home therapy teams that go into and work with. The rightmost rectangle talks about probable PTSD, post-traumatic stress disorder. In this situation, in addition to everything else described, we also begin to consider medication. So this is a continuation of the same pathway, trauma pathway. This focuses on the different therapy modalities that are available. One is trauma-focused cognitive behavior therapy. This focuses on the child, identifies how there are changes in how the child is approaching the world, how it interprets cues, social cues from the world, or misinterprets social cues from the world and sees the world as threatening, unsafe, and insecure. And that is when the behavioral dysregulation happens. So if we are able to identify what the child is thinking, then we can help the child modify that thinking to understand safety cues in the environment, whom to trust, and how to modify behavior so that they are asking for help instead of falling apart and becoming aggressive. The second one is for really young children. This 10-year-old's mom has an 18-month-old. We have a duty towards the 18-month-old child too, to make sure this child is not traumatized. So child-parent psychotherapy, and the next one also applies, parent-child interaction therapy, basically teaches the mother what to do with the child when the child is upset, how to soothe the child, how to teach the child to ask for help. very often, mothers in this situation have not received good parenting themselves. There is a concept of intergenerational trauma. So this mother, when she was a child, it would be important to know what her experience was. Has she been abused? Has she been neglected? Was there violence, domestic violence in the home? Is that what we are seeing play out now? The mother has her own children. She has 5 children and she hasn't been able to keep all of them. We also want to consider all the strengths of the family. If you think of the child, she's curious about the medication. She's like, my doctor wrote just 1 medication. Why, nurse, are you giving me 2 pills today? And that is important to develop. She should question. She should ask, what is happening in my care and be involved in that care. This child also said, I want to be with my grandmother, or I'm interested in seeing my mother. That also denotes some positives in that connection that she has. So she is capable of forming good connections, and a good connection is the basis of healthy relationships and good health, whether mental health or physical health, right? In terms of the mother, there are strengths there. She is able to identify that I was a child just like this 10-year-old when I was little. And she wants to be with this 10-year-old. She wants to be with her 5 children. So there is a commitment that she's bringing to this relationship. If she were given support, if the mother received support in terms of therapy, individual therapy for herself, if she needs medication, there was a mention that court-mandated treatment happened for 1 year. Can this mother continue with treatment so that she gets the help she needs? And this parent-child interaction therapy, right? So that she gains confidence in her skills as a mother. Similarly, the last is attachment, regulation, and competency, which is something that is used for a little bit older children. Once they get an idea of how attachments are important and how disruptions in attachments have caused mental trauma for them. After they have acknowledged that, they teach the child how to form healthy attachments. Because with a long history of unstable households, who the child lives with, what their attachments are like, child abuse, it is hard for the child to know who to trust, right? So they teach the child how to form positive attachment relationships and the ways to regulate themselves. If there is something in the environment that the child perceives as threatening, looking for cues to figure out whether it is indeed threatening or not, and how to calm down in the moment. And competency skills are focused on the resilience of the child. So you look at the child's strengths and you grow those strengths in a supportive environment. And in this particular instance, school can be a huge support. So when we look at the systems of care, we are definitely looking at the family system because that's where all the trauma happened, and that's where all the support and growth is going to happen, and the care is going to happen. We are looking at the school system because with the new school that she went to, I'm curious to know if the learning supports from the old school went to the new school. If the key counseling figures in the old school, whether it is a teacher who was kind to her, transferred information about the child and her behavior to the new school, right? So the school system is very important. The level of care within the hospital and the clinic system is also important because this child has shown attachment with the healthcare team. And that shows something huge in terms of her strength. With the number of different changes in attachment figures and the number of times she has been let down by people in her life that need to be caring for her but actually abusing her, that she was able to form a connection with the healthcare team says kudos to the healthcare team. You are doing an amazing job. And you want to utilize that. You want to build on that relationship to show her how the rest of the world that she enters into can provide those supports as well. I'm going to go on to talk a little bit about medications because I saw this child was on a combination of heavy-duty medication. And with young ones, especially with trauma, here in Boston, what we tend to do is start up with sleep. Is this child sleeping? And if this child is not sleeping, you can be assured that they're going to be irritable the next day. They're going to be angry and impulsive and aggressive, even if they didn't have ADHD, right? Even if they didn't have trauma. If a child is not sleeping, their behavior is going to be impacted. So we start up with melatonin, a hormone our body produces, step it up a little bit to the alpha agonist, clonidine, for instance. If there has been significant trauma causing nightmares in the child, and that is disrupting sleep, we treat the nightmares specifically with a medication, alpha-1 agonist, Presentación, right? And this is a phone consult that would happen. And if there are hyperarousal symptoms, I had mentioned how in the ADHD, alpha-2 agonists are tried for hyperarousal. If a child is hypervigilant, this medication, this class of medication can be very helpful. So impulsivity coming from trauma, impulsivity coming from disruptive mood dysregulation disorder, or impulsivity coming from ADHD. In all these situations, our go-to is the alpha-2 agonist. If that doesn't work, then we step it up to something like aripiprazole was one of the medications we saw in this child. Previously, this child was on risperidone. That's another medication we might try, especially if there are developmental disorders like autism spectrum disorder that is contributing to the aggression. And then if there are negative alterations of cognition, whether it is anxiety disorder, depressive disorder, or dissociation. Children with trauma can often dissociate from their surrounding environment. In all those situations, the selective serotonin reuptake inhibitors, which you saw in the anxiety care pathways, and depression care pathways are utilized. And finally, these are the levels of care. So mobile crisis team is involved with the children here who are traumatized so that they can go into the home and provide stabilization if they're dysregulated, or into the school. If a child is unsafe, obviously they go to the ER and then get admitted to a residential program like a community-based program or an inpatient hospital-based program, like this child was. There's also an intermediate level of care, a partial hospital program, where a child, if they are safe at home, will go in during the day instead of going to school, right? And it's for 2 weeks. They go in the morning at 9 o'clock, come back home at 3 o'clock. And there's intensive therapy during the partial hospital program. Child still comes back to attachment figures to sleep and to eat their meals with their siblings. And medication adjustment can happen with the nurse and the doctor in the partial hospital program. So that's an intermediate option as well. We often, after admitting to the hospital, we will step down to the partial hospital program so that the child can still have medical professionals working with them to monitor, and the child spends just some time at home and make sure that the home behavior is okay. If we need to fine-tune the medications a little bit more. At that time, we also have parent meetings so that the parent knows what to expect and what to do if things are not going according to the plan. And this is guided self-management for child to learn. This is for emotion regulation. This is also available free on our website, Building Bridges of Understanding. This is for anxiety, but it also applies to trauma. We teach young children things that you can do if you're feeling anxious, right? So we self-monitor, teach a child to self-monitor for anxiety. Is your chest tight? Is your heart racing? So that's the fear thermometer. And then when the child is in a calm space, we teach relaxation skills and have them practice it. This can happen at home. This can happen at school. So that when they become dysregulated or know they're becoming dysregulated, they can bring in these relaxation skills. We teach a child to identify thinking traps, meaning After experiencing trauma, like even bullying, right, at schools, children start thinking, oh, I'm not a good person, or I'm not smart enough. That is why these bad things are happening to me. So those are thinking traps, which we identify, and the caregiver is taught to change that thinking trap and make it more positive. And we teach the caregiver to help the child face their fears. So this is what the parents can do. One, they teach a child, yes, what you're feeling is real. Don't dismiss that feeling, but also encourage them to choose brave actions. So face the fear, reward brave actions. And very often, when we see a child in distress, we are distressed. We don't want our child to be hurt. So if we show in our face that the anxious child, we are also anxious, then there is going to be negative modeling. But if we model positive, brave actions and manage our distress and keep it inside, then we are teaching the child, yes, you can do this. You can manage your fear. I am here for you to help you. And right in the middle is a workbook that we use for young children. It says what to do when. It is a series. This one is for anxiety, so it's worry, but we also have something for depression, something for, a child who is afraid to go to sleep at night. So sleep issues. This is a series that can be really helpful for the parent and child to work on, and it is based on cognitive behavioral therapy. In terms of innovations, I'm going to go really quickly through these slides. Our program, MACPAP program, has a mother-child program, which I felt would be so helpful for this 10-year-old's mother. So our mother-child program was started in 2014. It is MACPAP for moms. And it was started because we realized, just like with this child, mothers who are traumatized often replicate the trauma in their parenting. And when expectant mothers come to the clinic for prenatal care, right, we can identify 60% of mothers who are going to develop mental health problems when they come to the clinic by administering rating scales. And we also found that 75% of mothers don't get treatment. Just like this mother, they don't get treatment because the focus is on the baby, making sure the baby gets a vaccination, making sure the baby is getting fed. So if the mother is identified and treated, the outcome is good both for the mother and child, but also the whole family unit, because there are other siblings, right, that we need to be considerate about. So that is MACPAP for moms. The consultation happens in this case between adult psychiatry and OBGYN, obstetrician gynecologist. So obstetrician starts prescribing medication or offers, resources for therapy for the mother. Then we have autism spectrum disorder and intellectual disabilities program, started in 2020 during the pandemic because we saw a huge rise in cases of phone consults coming for these kids because community services were all closed down. Also during the pandemic, I had mentioned substance use was a problem for teens. So we started offering virtual counseling for children. And this is, I'm going to talk about this program in just one slide. And finally, the newest program for us is for early childhood children under 6. So this is for MACPAP for moms. Right now, we have 85% of births in the state covered by MACPAP for moms. So they can call a psychiatrist, OBGYN can call a psychiatrist and get some help. I'm going on in the interest of time, but hopefully I can stop and take some questions towards the end. This is Primary Care Plus for addiction. It takes children who are just experimenting with substances or completely addicted to substances, gives them outpatient treatment. Parents can come asking for support even if their children do not want to stop the medication. And there are also referrals that can happen if the patient needs to be admitted. It is very collaborative with primary care. Primary care doctors can prescribe medications in consultation with addiction medicine specialists in this program. And then for early childhood, we typically don't use medications in children less than 6. We try to manage behaviorally, but there was a limitation in terms of resources. So this program offers those resources with short-term therapy for behavior therapy, behavior management in the community for anybody who calls, for the pediatrician that calls the MedPAP line. And finally, this is an offshoot of that program. We found that children with autism were not getting a timely diagnosis of autism, which only if they get the diagnosis, they get the services. So after we started up the previous program for early childhood, to expedite autism diagnosis, if a pediatrician is concerned, they can call this line and say, I want this child to be tested for autism. And then we expedite the services. To the left, you will see if there is complexity like trauma. Then we do further triaging to make sure that it is not trauma that's causing autism-like behaviors. So, with this 10-year-old, the developmental milestones were all normal, but early childhood trauma or in utero exposure to substances might mean that the developmental milestones are not normal. So we need to be able to tell it apart. And finally, putting together all our developments and new directions, because we have a workforce shortage in the US, this program was developed. And since this program was developed, we were able to make sure that 2/3 of mental health presentations are actually managed in primary care in consultation with a child psychiatrist. Telehealth has been a huge help in increasing access to care for remote areas and rural areas. And we have also started offering super specialty collaboration. For instance, addiction psychiatry, addiction medicine is one of them. And we've started training child psychiatry fellows as well as pediatric fellows in this model. And we've started adapting it to provide, there's a current pilot happening in 2 schools in Massachusetts so that, we can treat the child where they are at. Parents don't need to bring them anywhere else. And this is also applicable to other settings. And finally, take-home message. Access programs provide increased reach for child psychiatry expertise. And as a result of that, mild to manage mental health presentations being managed in primary care means specialty child psychiatry manages severe presentations or complex presentations. And for health equity, in the US, we have a huge problem with impoverished communities and minority communities not receiving services. So racial and ethnic minorities don't receive the same kind of services because of a lot of social determinants of health. Now, telehealth and child psychiatry access programs help to address some of these health equity issues. And finally, a large part of what we're doing is really because of the federal funding and the national health policies which support us. We wouldn't be able to do this work without that. These are my references. Thank you so much for your kind attention. I will stop share and see if there are any questions for me.
Muchísimas gracias, Deepika.
Thank you so much,
Gabriela,
Deepika.
¿tú quieres hacer algún comentario?
Maybe Gabriela would like to make a comment.
Y después capaz que algunas preguntas que
And
surjan, ¿no?
then maybe there could be questions. Well, I rather give way to questions because we can make comments later.
Agradecen tu presentación, Deepika.
Well, they are very grateful for your presentation, Deepika.
¿Alguna pregunta que surja
Any
relacionada
questions regarding the different levels discussed by Deepika?
Yo tengo una consulta.
I have a
Capaz que la nombraron,
consultation.
pero
Maybe it was mentioned, but
¿Cuántos
I missed it.
usuarios
How many users
que son los usuarios del servicio?
do you have at your service? How many people do
How
you care
many
for?
users do I have at my service? Okay, so in my program, a statewide program, we have 6 academic centers. So Boston Children's Hospital is one of them, Tufts is one of them, Mass General, so other hospitals too. And each hospital has 2 full-time equivalent child psychiatrists, meaning they work, they cover the whole week. And the number of pediatric practices that are covered within Massachusetts are a little over 500. So all the pediatricians that are in the practices, we also have family practice doctors, nurse practitioners who prescribe medication in the pediatric practice who can call us. More recently, the therapist that is in the pediatric practice can also call us with questions.
En realidad te preguntaba
what I was asking
¿cuántos son los usuarios
how
del
many
servicio? O sea, ¿cuántos pacientes?
users do you have? That is, how many patients do you
Más o
care
menos
for?
el número que ustedes manejan
Ah.
Gross figures, according to the different centers. Massachusetts is a whole state. You are the Boston Children's Hospital. So what sort of population, what is covered by each hospital?
Okay, so that's a great question. Our hospital has the biggest pediatric practice organization. So we have 95 pediatric practices, and that translates to about 4,000 phone consults. So 4,000 phone consults for patients in 1 year. And out of that 4,000, about 1,500 to 1,800 are seen as direct patient contact. We don't retain the patient because our program is meant to provide recommendations for the pediatrician to implement. So we see the patient and then tell the pediatrician what to start. If the pediatrician has a further question, they can call us again, or they can ask us to see the patient again, and we will do one follow-up. Is that answering your question?
Muchísimas gracias.
Yes, thank you.
You're very welcome.
Disculpe, ¿puedo hacer una pregunta?
Claro.
Excuse me, can I make a question? Yes, of course. I have this doubt regarding the first level of care. Do you have pediatric psychiatrists at that level?
When you said the first level of care, you mean on the phone? Yes, we have a child psychiatrist. So what would happen is the pediatrician picks up the phone, makes a phone call. We have an administrative assistant, a social worker, who will pick up the call and ask what is happening. And so the pediatrician can call and ask to speak to the doctor. They can ask to speak to the therapist. They can ask to speak to the resource specialist. So if they say, I want to speak to the doctor, then I will pick up the phone next and speak. And this happens in 15 minutes of the pediatrician calling. So that's the window. If the pediatrician says, I just need resources in the community, the administrator will connect to the resource specialist, who will then call the family and give a list of places where therapy is available in the community. If it is a child under 6, though, typically it is a therapist that answers the phone. Because we try not to prescribe medication for children under 6. If the child is on medication and the pediatrician says, this child is on medication, I need to speak to the doctor, then I would come on the phone and speak to the pediatrician.
Gracias.
You're
Thank
very
you.
welcome.
Yo quería hacer una pregunta en relación a
I
este
have a
último
question
punto.
regarding this
Cuando uno
last
tiene acceso, ¿no? Desde el primer nivel de
item.
atención a
When you
las
have
pastillas,
access
por
in the first level of
la
care to
decisión
the
del uso
cards,
de un
the
psicofármaco,
decision to use
si
a
esa
psychiatric
decisión la
medication,
toma el pediatra.
is it taken by the pediatrician?
Sucede que después ese seguimiento, en algún momento,
Because
ese niño
at a certain point, the
es
child
valorado por un
is
psiquiatra de niños,
assessed
o ese
by a
seguimiento,
child
por ejemplo,
psychiatrist
que
or
de
during
indicación
follow-up
farmacológica
with this
hace
pharmacological
el pediatra, por
prescription
ejemplo, ¿no? Quien tomó la indicación y en
is
algún
done
momento
by
él,
the
lo discute el
psychiatrist
caso con un psiquiatra, por
and
ejemplo.
this
¿Cómo se
by
maneja
the pediatrician and then discusses the case with the psychiatrist. How do you manage that?
So it is tricky. What we do is, as I had mentioned, one part of our program is education for the pediatricians. So we educate our pediatricians on using the rating scales to help with the diagnosis. And we use the care pathway, so pediatrician can look at the care pathway to start a medication. Our pediatricians can diagnose ADHD, depression, anxiety. Trauma is a little bit harder. OCD is harder. Psychosis, bipolar, much, much harder. So that comes to us. But after we make a diagnostic clarification, we can tell them, according to this care pathway, please start Adderall XR 10 milligram. And that care pathway says how to increase it, how to monitor, so how many times the rating scale should be continued. If they have a question, like they start the Adderall and there's appetite suppression, the child is losing weight, they can call us again. We don't necessarily see the patient before starting medication. For complex patients or severe patients, severe case presentations, or they've tried 2 SSRIs, it hasn't worked. Then in those instances, we offer to see the patient. And then we might say, please start this particular medication, or this patient is too complex for you. Let me connect this patient to specialty psychiatry within the hospital. And then the patient continues with our specialty outpatient services. But that is a very small proportion of the cases. Ordinarily, we don't offer follow-up for the patient. But if the pediatrician says, I started the medication having side effects, please see the patient, then we will see the patient. I hope that makes sense.
José Pedro Rossi tiene la mano levantada.
José Pedro Rossi has raised his hand.
Sí, acá hablaba sobre, en realidad,
Yes.
este participante hablaba sobre
This
el caso.
participant was mentioning the
No
case.
sé, Gabriela, si siendo
Gabriela,
11:26,
it's
nos quedan pocos minutos.
26 past 11. There's little time, Gabriela.
Me parece que, bueno,
I think
muchísimas gracias por la
that we
presentación,
have
pero
to
bueno,
thank
nos abre un
Deepika
poco
for her presentation
la
that sort of
cabeza, ¿no? A esto que nos
opens
pasa frecuentemente
our
en
mind
Ana,
to this thing
Laura,
that frequently occurs. She's asking if you
que
can
uno
hear.
queda como muy pegado, ¿no? Muy pegado a una situación
Sometimes we're very
intenta pensar en alternativas.
close to
A mí me interesa
situations and
mucho
hard to think of alternatives.
saber,
I'm very
por un
interested,
lado,
Deepika, in knowing, on the
¿de qué
one hand,
forma esto está
how
incluido dentro de
this
las políticas de
included
salud, ya sea
within
del
the health
Estado, de
policies,
la
be they
ciudad,
state
¿verdad?
policies,
¿Cómo
federal
se
meaning
pone en
and
marcha
city
este
policies?
dispositivo que ustedes
How
tienen?
is this
Si es
device
una
you have?
iniciativa exclusivamente, de, por ejemplo, de la
But
universidad,
is it a
que queda
university
abierto
initiative
a la demanda de
open
la población,
to
o si
the
esto es
population's
parte de una
demand,
política
or
de
is this
salud
part of
desde
a
el sistema?
health policy that pertains to the system?
That's an excellent question. So prior to the program being started in 2004, in 2003, there was a lawsuit started against the state of Massachusetts by the family of Rosie D. This child killed herself because she was waiting for so long for mental health treatment. And the family saw that this was happening to all the other children. There are very few child psychiatrists. So because of that lawsuit, the state said, we need to be able to take care of children with mental health needs. So the government started the program. 6 major medical centers offered their child psychiatry departments to run the program. So different parts of the state, we were initially in person, so the families would come to us in person for the direct consultation. After that, what we found is that commercial insurance, families that have money and commercial insurance, they were also having child psychiatry shortage. But the state government was having to pay for those families because our program is funded by the state. So the state government said all commercial insurance companies should pay a small proportion for our program. So now we have both state government funding and commercial insurance funding. And if the patient comes to see us face-to-face, then we do charge the commercial insurance for the visit. The state funding is just for the phone consults.
Sí,
Yes.
unido a esto, otra pregunta.
Together with this, there's an
La
additional
consulta
question.
inicial esta
The
de telemedicina,
initial
digamos, ¿no?
telemedicine telephone
¿La hace
consultation,
directamente el
is
usuario
this done
o
directly
ustedes la
by the
reciben a
user,
través del
or do you
pediatra
receive it via the
tratante?
pediatrician, the treating pediatrician?
So it is from the treating pediatrician. We don't speak directly to the user.
Perfecto. Y otra
Good.
pregunta.
And another
Perdón,
question.
que
Excuse
me
me.
despertaste muchas
You sort of awoke
inquietudes.
many
Siempre tenemos
concerns.
una duda.
We have
Sé
this
que no
doubt
hay a nivel
with us always.
internacional un
At
ranking,
international
digamos,
level, we know there isn't a sort of ideal
sobre la
ratio
cantidad
regarding the
especialistas
number
en
of
psiquiatría pediátrica en relación
pediatric psychiatry
al número de
specialists
pediatras. O
in
sea,
relation to the
cada
number of
cuántos
pediatricians.
pediatras deberíamos pensar
How
en
many
tener un especialista en psiquiatría
pediatricians need
pediátrica.
a
Y lo
specialist
mismo en
in
relación al
pediatric
número de
psychiatry,
menores.
and the
Nosotros
same
tenemos
in
algunos
relation to the number of
estimados
children. We have some
de lo
estimates
que es la realidad nuestra
of
y
our
también algunos
reality
estimados en
and
relación a
other
la
estimates
población que
regarding
demanda
the
atención. Pero no sé
population
ustedes con qué
demanding
números se
care.
manejan.
But I would like to know about your figures.
¿Cuál
Sure.
sería el ideal? Porque una
What
cosa
would
es lo
the
que queremos.
ideal
¿Cuál
be?
sería
Because
el ideal?
reality is one thing. What is the ideal?
So the way our program is designed is that we have one child psychiatrist for 500,000 children. We are also short-staffed, but if you look at the whole of the US, there are 8,300 practicing child psychiatrists, and most child psychiatrists are either in Massachusetts, my state, or in California. So we have more child psychiatrists relative to the rest of the country. So our state numbers are better. Most of our academic institutions are in Massachusetts. But,
Así que tienen uno cada 500
So you have
mil
one
niños.
every 500,000 children. Did I understand correctly?
It-
One
it's,
per every
so
500,000
if
children.
you include the whole country,
Country,
country, that's why I was saying in Massachusetts,
Yes.
there are way more child psychiatrists, there are way more child psychiatry training programs. But I can look up the number and give it to you if that is of interest to you, because Massachusetts is not
Y en
the
relación a los
real-
pediatras,
And in relation to pediatricians,
ustedes, por ejemplo,
in
los
relation to the
pediatras,
pediatricians.
for example,
So
pediatricians.
we have like 500 in relation to pediatric practices. We have 8 doctors, 8 child psychiatrists for the 500.
Ya, perfecto. Bueno,
Good,
no, me
thank you.
parece muy interesante
I
porque
found it
esto
very
puede
interesting
nutrir
because
algunos
this
proyectos que
can
nosotros tenemos
contribute
en
towards
marcha.
some of our ongoing
Concretamente
projects,
uno,
more
que
specifically
haya
one
publicado
that
alguna
has
primer
published
informe
a
sobre
first
el uso de
report
telemedicina
regarding the use of
para
telemedicine
diagnóstico y los primeros abordajes de niños
diagnose
con
and
trastornos del
initial
neurodesarrollo.
approach of children
Y esto
with
no es un trabajo solo
neurodevelopment
exclusivo del
disorders.
psiquiatra pediátrico, sino
This
desde un
isn't a
equipo
work done only by the child psychiatrist, but
enfocado
by
en
an
desarrollo.
interdisciplinary team
Creo
focused
que
on development.
estos
I
recursos que
believe
ustedes
that
nos
these
muestran
resources you're
pueden ser
sharing with us
enriquecedores para
could
estas nuevas
be
iniciativas
enriching
y
for
también
these
para
new
pensar
initiatives, and also
dónde
to
nos
think,
ubicamos, ¿no?
where
Cada
are we
uno de los
placed?
especialistas o cada
Each
uno
of
de
the
los recursos. Creo
specialists
que la
or resources.
historia de hoy
I believe that today's
muestra un
case history
poco
somehow
esa
shows
especie de
sort of
sobreposición
overlap
que muchas veces
that sometimes
tenemos nosotros en nuestro país.
occurs in our country.
Laura, te dejo que tú hagas
Laura,
el cierre, por ahí hay
you
una
can
mano
close.
levantada.
There's a hand raised, I don't know.
Agradezco infinitamente.
Thank you so much.
No, yo solo quería comentar que
I
tenía la
just
mano
wanted to
levantada, de
add
hecho,
that
un par de comentarios que
I
dice,
had
parece un
raised my
abordaje
hand because
multifactorial, con aspectos con más
the comment said it's a multifactorial approach with more emphasis on the pharmacological treatment and less on the dynamic relationship with the mother and child. The girl showed a lot of potential. So I think throughout Deepika's presentation, and we're very grateful, you helped us to reflect upon this. And later we may exchange further with the team in the territory some aspects related with the approach, and as people said, the different components we must consider when approaching very complex situation, issues regarding the child, his or her mental health, the mother's mental health, the attachment, relationship, trauma. So we have homework. We'll discuss this together with Daniela because we've really debated this case. That's why we wanted to share it. And I want to thank the people from the ECHO team once again for enabling all this, because it's been very easy to follow Deepika's presentation. That was very clear, but because we had the interpretation also, so we hope we can meet again, because we visit you in Boston or in another ECHO activity we can share.
Thank you so much for this great opportunity. I really loved, the thoughtful discussion and very interesting questions. And Dr. Garrido had shared that particular program. It is very similar to our autism spectrum program. So happy to talk more about it. If you have further questions, please do share my email to anybody who's interested in collaborating with me or has further questions. I know we are short on time. Thank you so much for the kind interpretation services provided as well. Thanks, Lucia. Really appreciate everybody here.
Muy bien, bueno, nos despedimos hasta la próxima teleclínica.
Goodbye, and we meet in the next teleclinic. We will have adult psychiatry in June. Have a good day.
Thanks, everyone. Bye-bye.